Okay. So أول سؤال, first question I want you to ask yourself is, why do we need to study breast diseases? First of all, benign and malignant conditions are extremely common هنا في السعودية, and I'm assuming it's the same thing in Kuwait. It will
Doctor,
constitute...
sorry to interrupt you, because a lot of our audience are from outside the Gulf. So
Okay.
if we can just keep it in English, it would be...
All right, sure.
Thank you
Absolutely.
so much.
Okay. It will constitute a major proportion of your practice as a general surgeon. So when you graduate, if you start practicing as a general surgeon, you'll be seeing a lot of breast diseases, the benign and the malignant. And of course, to pass the exam, because usually board exams are heavy on breast. Okay. Sources, there are a lot of sources to read from for the breast. Sabiston, Cameron, the NCCN guidelines are very good for pathways, or when you study together and then you have a question and you're not sure what's the right answer, you could always go back to the NCCN guidelines. Toronto Surgical Oncology Manual, it's a very small book that covers all of the surgical oncology diseases, including breast. It's very nicely summarized and has the landmark trials behind all of the guidelines that we memorize for the exam. And the MD Anderson Handbook is also a small book, but it's also a nice summary for breast cancer. Okay. So we'll be covering a lot of topics today. We'll be talking about early breast cancer and locally advanced breast cancer, DCIS, the management of recurrent breast cancer, new trends in managing the axilla, especially we'll shed light on the Z11 trial and the AMAROS trial, how to deal with breast cancer during pregnancy, and phylloids. Okay, so the natural history. This is a normal duct of the breast with a single layer of epithelium. When normal cells just replicate more than the usual, you're going to have what we call ductal hyperplasia, or if this is happening in the lobules, we're going to call it lobular hyperplasia. And this is a benign condition. Once the replicating cells start to be atypical, it's the beginning of the cancerous process. So once we see atypical hyperplasia, it's the point that we know that from this step on, the next step would likely be DCIS, followed by invasive cancer. But let me tell you, not every atypical hyperplasia will become DCIS, and not every DCIS will become invasive cancer. However, because we can never tell, if somebody, we biopsy them and they have atypical hyperplasia, there is no way for us nowadays to know whether this is the type that will progress to malignancy or not. And that's why the management of this condition, starting from atypical hyperplasia all the way to carcinoma, includes surgical excision. In the Toronto Surgical Oncology Manual, you're going to find 2 pages about different pathological terms and findings that you could find after you biopsy a lesion seen on mammogram or ultrasound. It's very nicely summarized. It tells you the definition, how to treat it, and then if there are any specific comments about the risk of harboring malignancy, you can keep it as a reference. But what I want you to pay attention to, especially for the exam, anytime you see the word atypia, such as atypical ductal hyperplasia or atypical lobular hyperplasia or flat epithelial atypia, anytime you see the word atypia, you should absolutely on the exam mention that you're going to excise the lesion. So sometimes I tell the residents, when I get the pathology report of a breast biopsy, it looks like this. And as a surgeon, all what I'm looking for is the word atypia, because this is actually what's gonna change my management. If I see sclerosing adenosis, florid ductal hyperplasia, lobular hyperplasia, all of the other findings, it doesn't concern me. It's the word atypia that makes us alarmed and warrants surgical excision. So when do we take out any breast lesion? As we said, if we see the word atypia, we take it out. If there is discordance between radiological finding and pathological finding, then we have to take it out. For example, if the radiologist tells me it's a BI-RADS 5 and the biopsy comes as fibroadenoma, we're definitely taking it out because this is discordant. And if we cannot rule out malignancy, such in a condition like radial scar and fat necrosis, it's sometimes hard to exclude malignancy. So in that situation, you take out the lesion. All right, lobular carcinoma in situ. So it's not considered a malignancy, nor that it's a pre-malignant condition. It's not like DCIS. The natural history of DCIS is to become invasive cancer. Lobular carcinoma in situ is not the same thing. It's basically a marker for the patient that she is at a higher risk of subsequent carcinoma in that breast, in that area, elsewhere in that breast, or the contralateral breast. So the risk is for both breasts and it's lifelong. The NCCN guidelines recommend excisional biopsy to rule out adjacent DCIS or invasive breast cancer. The point with LCIS is that it's not seen on mammography. So if you do a mammogram and then the radiologist tells you that she sees microcalcification, you take a biopsy through image guidance, and then the pathology comes back as LCIS. Let me tell you with certainty, they missed the calcifications, because lobular carcinoma in situ is something that you see in the background of the tissue, and it's not something you see on mammography. So if this happens, you have to go back and take the area of the calcification to rule out atypical ductal hyperplasia, DCIS, or invasive cancer. For LCIS, if you take any lesion and there is LCIS in the margin, there is no need to go back, because as I told you, LCIS does not progress locally into malignancy. It's just a marker of high risk. One specific subtype of lobular carcinoma in situ is pleomorphic lobular carcinoma in situ. It needs complete excision to negative margin because it mimics DCIS, and there is a higher chance of finding DCIS or invasive cancer when you see the word pleomorphic LCIS. Here are the NCCN guidelines. So if you identify lobular carcinoma in situ on a biopsy, and there is nothing else, like you saw whatever that explains the microcalcification, for example, sclerosing adenosis, and you saw incidentally classic lobular carcinoma in situ, then this is the classic LCIS, and we're going to talk about how to manage it. If the biopsy tells you that there is pleomorphic LCIS, then you have to perform a surgical excision to rule out DCIS or cancer. If there is any discordance between the biopsy finding and the pathology, like you see microcalcification or something suspicious and it only comes back as LCIS, as I said, then we missed the lesion. You have to go back and perform surgical excision. So once classic LCIS is diagnosed, we have three options to discuss with the patient. The first option, and it's the most common one that we use, is close observation. If you're dealing with an educated patient who is committed to their annual follow-up, who understand what is this condition and what's the risk, then yes, close observation is a good option. We call it chemo prevention, but it's not actual chemo, it's just prevention using medications such as tamoxifen or raloxifene. And the most aggressive mean of decreasing the risk of cancer from LCIS is bilateral mastectomy with immediate reconstruction. This is an option that we usually discuss when we're dealing with very young patients. We tell them that they're very young and their lifelong risk of malignancy will be high, so it's better to deal with it surgically rather than taking tamoxifen and dealing with the side effects for many years. A 5-year course of tamoxifen provides 56% reduction in the risk of breast cancer, both sides. All right, ductal carcinoma in situ. So as we said earlier, the natural history of ductal proliferation is going from atypical ductal hyperplasia into DCIS, then invasive breast cancer. And as we said, because we could never tell which DCIS will become cancer in the future, that's why up till now, the guidelines recommend surgical excision for ductal carcinoma in situ. So multifocal multifocal disease and multicentric disease. Those are terms that you will find radiologically for cancer and for DCIS, and you will need to know them because they will affect your surgical management. So multicentric disease, it means that there are foci in two separate quadrants of the breast or within the same quadrant, but there is at least more than 5 centimeters between the foci. Usually multicentric disease is an indication for mastectomy. Multifocal disease is defined as the presence of 2 or more foci within a single quadrant, or they're within 5 centimeters of each other. For multifocal disease, you could offer the patient lumpectomy if she doesn't have contraindication, but it's preferable to do on-table frozen to decrease the risk of needing going back to the operating room for negative margin. Another term that you're going to hear with DCIS is microinvasion. So basically, DCIS is cancer cells inside the duct. So those are the cancer cells, but they're confined inside the duct and did not cross the basement membrane. That's classic DCIS. When we say DCIS with microinvasion, it means that some of the cancer cells, like this little buddy here, cross the basement membrane, but within 1 millimeter. So it is basically invasion, and we treat it as invasion, but they like to call it DCIS with microinvasion. How would that come up on the exam? If you see DCIS with microinvasion, then you're gonna offer the patient sentinel lymph node biopsy, because the risk of having lymph node metastasis once there is crossing the basement membrane goes from 0 in classic DCIS up to 20%. So as we said, classic DCIS does not go anywhere. It's confined to the duct. So there is no risk of metastasis to the lymph node or systemic. However, sometimes preoperatively, clinically and radiologically, you're concerned that even though that the biopsy just showed DCIS, you really believe that this patient is risk of having invasive carcinoma. So sometimes we offer the patient sentinel lymph node biopsy at the same time at the surgery for the DCIS, although we know that it doesn't go to the lymph nodes. So what are those findings? Presence of a palpable mass, nipple discharge, high-grade DCIS and comedonecrosis, DCIS in a large area over 4 centimeters. Even if the biopsy tells me that this is DCIS, when I see those findings, I will be a little bit more suspicious that the patient is having an actual invasive focus within that area of DCIS, and I will recommend that we do sentinel lymph node biopsy. If prior to surgery, pathology already mentioned that this is DCIS with microinvasion, then again, we're gonna proceed to sentinel lymph node biopsy. Any patient getting a mastectomy must have sentinel lymph node biopsy at the same time, even if it's pure DCIS on biopsy. The reason is that there is 10 to 15 chance that after you remove all of the breast tissue and you send it for pathology, a week later, the pathology report will come back and they will tell you that they actually found a focus of invasion in that area of DCIS. And then at this point, we're a bit stuck because we removed all of the breast tissue. How are we gonna do our sentinel lymph node? So that's why if you are doing mastectomy for a DCIS patient, you absolutely have to do a sentinel at the same time. So how do we treat DCIS? First step is surgery. As we said, total mastectomy with sentinel lymph node biopsy. They come together in DCIS, or breast conserving surgery, plus minus sentinel lymph node biopsy. If there is something from the previous slide that tells you that the patient is at risk of having invasion, then you will do the sentinel at the same time, followed by radiotherapy. And then plus minus hormonal treatment. The B17 and B24 are the large trials that the recommendation for radiotherapy and hormonal treatment came after. What are the indications to do a mastectomy? Multicentric disease, and this is usually predicted pre-operatively on mammogram. When you see extensive microcalcifications, it's usually a sign that it will be multicentric disease. The area of DCIS is large relative to the breast size. Clear margins cannot be obtained with breast conservation. Contraindication to radiotherapy, such as prior radiotherapy, pregnancy, active connective tissue disease. And I want you to remember, comedonecrosis by itself is not an absolute indication for mastectomy. If you have a 2 centimeter focus of DCIS, even if there is high grade and comedonecrosis, it's not by itself an indication to proceed to mastectomy. So after surgery, what are the adjuvant treatments that we could offer? Radiotherapy and anti-estrogen treatment. So why offer radiotherapy after lumpectomy for DCIS? Many large trials over many years of follow-up have demonstrated that there is very good risk reduction in recurrence after radiotherapy for lumpectomy. This is the NSABP trial, and you can see the huge difference between cumulative incidence of recurrence between radiotherapy group and no radiotherapy group. This is another European trial over very long follow-up, over 20 years, showing that the radiotherapy group had better survival. This is the Swedish trial. Again, it demonstrates that patients receiving radiotherapy had lower cumulative incidence of recurrence. And this is the UK trial, again, control versus radiotherapy. Radiotherapy arm had lower ipsilateral recurrences. All those 4 big trials combined in a Cochrane meta-analysis, and you could see that it's in favor of radiotherapy with a hazard ratio of 0.5. So 50% reduction in the risk of local recurrence. And that's why every patient that has a lumpectomy for DCIS, we refer them for consideration for radiotherapy. But remember, more is not always better. Sometimes we can omit radiation in some patients. Everything that we offer and all interventions given to the patients have their side effects. So if there is a patient that would be a good candidate to omit radiotherapy, we will. So how do we decide? Van Nuys prognostic index is very important to know for your exam. It's based on 4 factors, and it's a score that ranges from a minimum of 4. So if they get 1 on each of the 4, then this is the lowest, or a maximum of 12. For those who get a score between 4 to 6, they have very biologically biologically favorable disease, and their chance of having recurrence is already low. So there is a good chance that we could discuss with them omitting radiotherapy. Patients that have a very high Van Nuys prognostic index between 10 to 12, those are the patients that we would actually offer them a mastectomy, given that they have a very high chance of recurrence. So what are the 4 factors? First of all, tumor size. So the bigger the tumor, the higher the points. So 15 millimeter, 16 to 40, and then more than 40 millimeter. Margin width. So the higher the margin width, the lower the score. So either more than 1 centimeter, between 1 to 9 millimeter, or less than 1 millimeter. Tumor nuclear grade and necrosis. Again, the higher grade and the comedotype necrosis gets 3. And then the age. The younger the patient, the higher the points. So 1 is for over 60, and then 3 is less than 40. So for example, if I have a 65 postmenopausal lady who had a very small focus of DCIS of 1 centimeter, and they have very good margin, over 1 centimeter. And the DCIS was low grade and no comedal necrosis. So this lady has a total score of 4. This lady, she already has a very low risk of local recurrence. So at this point, given that she has an extremely low risk of recurrence, cutting this super low risk of recurrence down by 50% is not really that meaningful when you compare it to the side effects of radiotherapy. So I would discuss with this lady omitting radiotherapy, as opposed to a 35-year-old female who has a very large area of DCIS, let's say 5 centimeter, and we did lumpectomy and the margins are very close, and she has high-grade DCIS with comedal necrosis. So for this lady, what I'm gonna actually do is that I'm gonna offer her mastectomy. It doesn't mean that she has to go, but we're gonna discuss it with her. If she does not want the mastectomy, she gets the radiotherapy. Anti-estrogen therapy for DCIS. Again, it decreases the local recurrence in the ipsilateral side, and it's a preventative medicine for the contralateral side. The number needed to treat is 15. So basically, for each 15 women taking tamoxifen after DCIS treatment, you are preventing a recurrence in one of them, which is not bad. Who do we consider it? It's not for everybody. Obviously, first of all, they have to be ER/PR positive. We discuss it with young patients, given that usually DCIS in younger patients is more aggressive with higher chance of recurrence. If the area of DCIS is large, more than 4 centimeter, if there are positive margins that cannot be revised, for example, I did a mastectomy for extensive DCIS and they said that the margin is extremely close to the posterior area, close to the muscle. You're not going to go back and remove the muscle for DCIS, but this is one of the things that you could offer the patient to decrease recurrence, radiotherapy or anti-estrogen treatment. Patients with high-grade comedal necrosis also are considered for anti-estrogen treatment, and strong family history. So these are the patients that we discuss with them anti-estrogen treatment. The NCCN, in their most recent update about the use of anti-estrogen treatment for DCIS, they clearly said that available data suggests that it provides risk reduction in the ipsilateral breast treated with breast conservation and in the contralateral breast, but it's only for ER positive tumor. The problem that we have is that we do not have any trial that demonstrates major survival advantage for using anti-estrogen therapy for DCIS. So that's why we have very select group of patients that we discuss with them anti-estrogen therapy for DCIS. So, summary for DCIS, once it is diagnosed, you have 2 options. First step is surgery. Either I'm doing a lumpectomy and the required margin for DCIS to minimize the risk of recurrence is 2 millimeter. And if I'm doing a lumpectomy, I'm doing a radiotherapy. I put here a note that I can omit radiotherapy based on Van Lees prognostic risk index. And then after that, plus minus anti-estrogen treatment if there is an indication, one of those. Again, back up to surgery. If not lumpectomy, there is a contraindication to lumpectomy. I'm doing a mastectomy plus sentinel lymph node biopsy. Only discuss radiotherapy if you have a margin close to the skin or the chest wall, and plus minus anti-estrogen therapy, same indication as here. So as I discussed earlier, because not all DCIS progress to cancer, there are now 3 large trials that are running in North America that are looking at either observing DCIS or putting them on anti-estrogen treatment and not offering surgery. And it's basically for the low and maximum intermediate grade of DCIS in compliant patients who are going to commit to close follow-up. And then after those results come out, we might actually see significant results of omitting surgery in certain group of women. So we're gonna skip the questions to the end. And now we're gonna start talking about invasive breast cancer. So it's a very large topic. We cannot cover everything in one lecture. I'm gonna skip the basics, the diagnosis, imaging, staging. I think all of you should know this because you're writing the exam. Remember, it's very important to do your risk assessment whenever you see a patient with breast cancer, even if they already got diagnosed with cancer. It's very important to ask about the family history, because if they have very high risk of genetic predisposition, then it will alter your surgical management. And there are two things I want you to remember for the exam and for the rest of your life. Once you see diagnosis of breast cancer, first question you ask yourself, am I dealing with early breast cancer or am I dealing with locally advanced breast cancer? They're two different diseases. Second question that comes to you as a surgeon, once you're ready to write the consent for the surgery, you ask yourself, what am I doing with the breast and what am I doing with the axilla? Take your time to decide what's the surgical option for the breast and what's the surgical option for the axilla. The new language for understanding breast cancer is the molecular subtypes. Luminal A is the most common, the ERPR positive, HER2 negative, and it's usually in older women. Luminal B is higher grade. It's ER positive, PR could be positive weekly or negative, plus minus HER2 could be positive or negative. HER2 breast cancer means ERPR negative, and only the HER2 is positive. Basal or triple negative is the last category, and it's the most aggressive. Those two are least aggressive, and that's why they do not respond to neoadjuvant chemotherapy. As opposed to those two here at the bottom, they're the most aggressive, but they do respond to neoadjuvant treatment. Okay. Don't you love this page? You're gonna find it in every book that talks about breast cancer. I find it very difficult to sit and try to memorize all of those little details about the T, the N, and the M. So what I always do is that I only memorize things that will alter my management. What I want you to pay attention to is the lymph node classification. If it ever mentions in the question NI+, I+ means isolated tumor cells. It means when they cut the node, they put it under the microscope, they saw very rare scattered tumor cells or a cluster that's not more than 0.2 millimeter. And it's considered N0, okay? So basically, N isolated tumor cells or NI+ is considered N0. We don't do dissection for this. We don't give chemotherapy for this, but it's a pathological classification we have to know. N-mic or N-micrometastasis. So it's a very tiny focus of invasive cancer inside the lymph node that's more than 0.2 millimeter. So it's a bit over the isolated tumor cell, but it's not more than 2 millimeter. And it's considered N1. And then the other schedule that you're gonna find, the other table that you're gonna find after the prior table is this one, and where you're kind of like stuck trying to memorize what's a stage 1, what's a stage 2, what's a 3, what's a 4 is easy, but it's always the difference between 2 and 3. So here's the way that I did it so I could memorize it for the exam. Stage 1 is T1 M-mic max. And then what makes a stage 3? We're gonna skip stage 2. What makes a stage 3 is 2, 3, 4, and the 4 is 3 plus 1. So this is the 2, 3, 4, and the 4 is 3 plus 1. So any N2 disease, Any patient who comes with fixed matted lymph nodes, automatically, she's a stage 3, regardless of what's the T. Any patients that comes with N3 disease, supraclav, infraclav, internal mammary, so N3 is outside the axilla, she's automatically stage 3. Any patient that comes with T4, skin ulceration, inflammatory breast cancer, chest wall fixation, automatically stage 3. And the 4 is 3 plus 1, which is T3 and 1. So now that we know stage 1 is T1 and mic max, stage 3 is 2, 3, 4, 3, 1, then anything that comes in between will be stage 2. Stage 4 is easy whenever there is metastasis. All right, so now that we diagnose the patient, the next question is going to be, what am I dealing with? Early breast cancer or locally advanced? Why does it matter? First of all, survival. So when you're sitting with a patient who has early breast cancer, you can tell the patient with confidence that she will most likely die from something else other than the breast cancer, car accident, heart attack, anything. Because their survival is over 90 to 100%. Once you see patient with locally advanced breast cancer, which is stage 3, their survival drops to 36 to 67%. And once you see a patient with distant metastasis, 5-year, 1 in 4 will be alive and the other 3 will be dead. So there is a major difference in survival between early breast cancer and locally advanced. Unfortunately, in Saudi Arabia, it's kind of switched the percentage here. We see more locally advanced breast cancer and less the early breast cancer detected by screening mammography. So early breast cancer is stage 1 and 2, T1, T2, and 0, and 1, T3, and 0. And usually when I'm seeing a patient with early breast cancer, the first step in management is going to be upfront surgery. So what am I going to do with the breast? We said we're going to think about 2 different organs, the breast and the axilla. So either breast conserving surgery plus radiotherapy versus mastectomy plus minus post-mastectomy radiotherapy. In early breast cancer, we always try to go for breast conserving surgery unless there is a contraindication, like multicentric disease, pregnancy, prior exposure to radiotherapy, etc. What am I doing with the axilla in an early breast cancer and we're going for upfront surgery? If she's clinically node negative, I palpate, I don't feel anything, the ultrasound for the axilla is normal, we're going to do a sentinel lymph node biopsy. If it's negative, we're done. If the sentinel lymph node biopsy is positive, the classic teaching is to go for axillary lymph node dissection, but we're going to discuss later on in depth that situation. But if the sentinel lymph node biopsy is positive, there is a very high chance that you could spare the patient axillary lymph node dissection and just offer them adjuvant treatment. If the patient comes already clinically node positive, palpable disease, or on ultrasound, they're suspicious and biopsy confirms that there are metastatic cells in the lymph nodes, then you're going to do axillary lymph node dissection. So this is early breast cancer, and we're doing upfront surgery. Breast 2 option, BCS plus radiotherapy versus mastectomy. Axilla, depending on the status, the nodes are clinically negative sentinel. If the nodes are clinically positive, then we're going for axillary lymph node dissection. In this category, it doesn't always have to be upfront surgery. Sometimes you might choose patients with early breast cancer and start them on neoadjuvant treatment, either because they're node positive and we think they will respond to treatment, so we can convert them from node positive to node negative, and then after that we do sentinel instead of dissection. Or if they have a T3 disease or even a big T2, like a 4 cm mass, and we want to downstage it to do a lumpectomy instead of mastectomy. here are the contraindication to BCS. It's more or less like the DCIS. And when it comes to doing breast conserving surgery versus mastectomy, old teaching used to be all breast cancer should get a mastectomy because this saves their life. And it wasn't really until the surgeon Bernard Fisher, who is one of the pioneer behind the NSABP trials, who did a large study and showed that radical surgery does not save life. So over many years of follow-up, this study, I think it started in the 80s, disease-free survival, distant disease-free survival, and overall survival, whether the patient had a total mastectomy or lumpectomy, they're all going together. So there is no difference in survival. So we should not tell the patient that we're gonna need to do a mastectomy to improve their survival. All right, so we're still in the early breast section. We talked about surgery, and then now we're talking about adjuvant treatment. What are the indications to do radiotherapy in early breast cancer? Obviously, immediately after breast conserving surgery. If I'm doing lumpectomy, I have to do radiotherapy. Or post-mastectomy in select patients, patients that have large tumors, more than or equal to 5 cm, close margins, extensive lymphovascular invasion. This is a pathological term that we look for when we're looking at the final pathology report. 4 or more lymph nodes, and nowadays, even any node-positive patient would be considered for radiotherapy based on recent publications of large trials. So every woman getting breast conserving surgery for breast cancer has to have radiotherapy. If she got a mastectomy, most of the time they don't need radiotherapy unless they have one of these. Adjuvant chemotherapy for early breast cancer, it's not always needed, but here are the indication. By tumor size, so if the tumor is less than 1 centimeter, there is no need for chemotherapy. If it's more than 2 centimeter, we refer them to get chemotherapy. Between 1 to 2 centimeter, becomes a little bit controversial, and this is the time when we send for more complex biological testing like the Oncotype DX and the Mama print to help us identify the risk of recurrence specifically in that patient. And if the risk of recurrence is low, we omit chemotherapy. If it's high, we give chemotherapy. By lymph node status, every female with breast cancer who has positive nodes has to be referred to medical oncology for consideration for chemotherapy. And by receptor status. So triple negative patients, they have to see a medical oncologist. HER2 positive, more than 5 millimeter in size, they have to get Herceptin-based chemotherapy. So early breast cancer, we talked about surgery, we talked about indication of radiotherapy, and now here, indication of chemotherapy, it's by size, by node, by receptor status. Oncotype is the one going back to the size. If it's high risk of recurrence, we're gonna offer them chemotherapy. Next is the anti-estrogen treatment, obviously only for the hormone positive, ER and PR positive. If the female is premenopausal, so estrogen is coming from the ovaries mainly, the only option is tamoxifen. We cannot give them aromatase inhibitors. You must know the side effects for tamoxifen and the contraindication. Major side effects is thromboembolism and uterine cancer. If the question comes up that the patient has thrombophilia or a condition that makes her prone for thrombosis, then it's a contraindication for tamoxifen. If the lady is postmenopausal, then we could either give them AI or tamoxifen. We usually prefer aromatase inhibitor because it's better tolerated, and studies have shown that the adherence to aromatase is better, and there is a slight survival advantage when using aromatase over tamoxifen in postmenopausal lady. The only contraindication to using aromatase inhibitor is having severe osteoporosis because it could worsen and then it could cause fractures and death. So if a postmenopausal lady has very bad osteoporosis, I would give her tamoxifen over aromatase inhibitor. Otherwise, we should offer aromatase inhibitor for any postmenopausal lady. Next, we're going to talk about locally advanced breast cancer. So what defines a locally advanced breast cancer? What we said earlier, T3, 4, and the 4 is 3 plus 1. Clinical N2, clinical N3, T4, which includes extensive skin edema, satellite nodules, fixation to the chest wall. Inflammatory breast cancer is by definition T4B, and T3N1. All patients with locally advanced breast cancer, they need full metastatic workup, including CT chest, abdomen, pelvis, and bone scan, even if they are completely asymptomatic. All patients with locally advanced breast cancer must have multidisciplinary approach. All of them should be discussed in tumor board. Even in the exam, you have to mention, once you identify in the exam that you're dealing with a locally advanced breast cancer or stage 4 breast cancer, you have to say that I will discuss this case at the multidisciplinary tumor board for further management. All of them should be considered for neoadjuvant chemotherapy. Don't forget to place a clip in the tumor if you are considering to do lumpectomy after chemotherapy, because sometimes you will see that the patient has a great response and the tumor had completely disappeared clinically and radiologically. So if you're considering doing a lumpectomy after chemotherapy, throw in a clip in the heart of the tumor. So even if the tumor disappears, you can put a wire in the clip and get the tumor area. Why neoadjuvant chemotherapy? I love neoadjuvant chemotherapy. I have like a 1-hour talk about why we should always consider patients with locally advanced disease for neoadjuvant chemotherapy. A lot of surgeons still practice the old way. They see patients with advanced breast cancer and they offer them immediate surgery, modified radical mastectomy. It's not always the right thing for the patient. The right thing for anybody with locally advanced to see a medical oncologist and start neoadjuvant chemotherapy. Why? First of all, evaluation of in vivo response. What does it mean? So when the tumor is there in the patient and I am giving her medication, I could actually monitor if the patient is responding to that toxic treatment or not. If I schedule my patient for 8 cycles of toxic treatment and I give her 1, 2, and 3 cycles and she is not responding, then the first thing that we're going to do, we're going to stop this regimen and we're going to switch her to a second line. However, if I see a locally advanced breast cancer and I jump on it and I do surgery, she will take the 8 cycles and we will never know if she was benefiting or not. So having the chance to evaluate the response in the patient is very valuable information. And as a matter of fact, it predicts survival. So if I have a patient with locally advanced breast cancer, and we said earlier, their survival is low, 36 to 67%, and I give them chemotherapy and they have a complete pathological response, I can tell that patient that now her survival is as good as an early breast cancer. So giving neoadjuvant chemo to monitor response is a very valuable tool. Downstage the disease, and the downstaging is in the breast and in the axilla. We convert a patient from a mastectomy candidate into a lumpectomy candidate, and we convert a patient from an axillary lymph node dissection candidate into sentinel lymph node biopsy candidate. Early introduction of chemotherapy to treat occult potential systemic metastases. The low survival in patients with locally advanced breast cancer is not from the T4 tumor or the ulcer that she has or the fixation to the chest wall. The low survival is secondary to the death from metastatic disease. So all locally advanced breast cancer are either, like as we see them now, their scans are negative, but they are starting to have metastases, or they will have metastases in the near future. So there is the theoretical advantage of introducing chemotherapy early on to treat occult systemic disease. And if the patient had occult systemic disease and she progressed during your chemotherapy, then you know by that time that she will not benefit from surgery, so you don't need to do the surgery for them. So what are the indications for neoadjuvant chemotherapy? Patients with inoperable breast cancer. IBC is inflammatory breast cancer. If you see inflammatory breast cancer, do not operate, even if you think you can do a beautiful modified radical and include all of the skin changes. Don't. Start with neoadjuvant chemotherapy. If you have bulky or matted axillary lymph nodes, if you have N3 disease, T4 tumors, or in patients with operable breast cancer, like the first category, the early breast cancer, sometimes we offer them neoadjuvant chemotherapy if they're HER2 positive or triple negative, T2 or more, or N1 or more. If there is a large tumor relative to the breast size, the T3, for example, N0, the patient is node positive and will likely become node negative after chemotherapy, then yes, even if she does not have the 2, 3, 4, and 3+1, we could discuss neoadjuvant treatment. And if time is needed to decide surgical option. So let's say I'm seeing a 35-year-old who her mom had breast cancer, her sister had breast cancer, and her aunt had breast cancer. So I'm suspecting that she has BRCA mutation, and I'm discussing with her bilateral mastectomy with reconstruction, and she wants to send for genetic testing, and this will take a couple of weeks. And at the same time, she has a borderline indication for chemotherapy, and she will likely get chemotherapy after surgery. Then we could discuss with the medical oncology, starting with the chemotherapy first, allowing time to decide for surgical options, and then do the bilateral mastectomy. This is from the NCCN guidelines. All right, so first step in the management of locally advanced breast cancer is neoadjuvant treatment. Now that they completed their treatment, we're gonna discuss with them surgery. So first question, what am I doing with the breast? Again, I have two operations. I could do a breast conserving surgery if they are a good candidate, if they had a big tumor and it shrunk, and it was not a tumor that was multicentric in the beginning or involving most of the breast. It has to be a unifocal area that responded to treatment. Otherwise, we're doing a mastectomy. Whom are potential candidates for breast conserving therapy after neoadjuvant? Unifocal disease, no inflammatory breast cancer, radiographic abnormality is resectable with lumpectomy on post-treatment MRI, no contraindication obviously to radiotherapy, and you have to make sure that you're offering this to a patient who is committed to follow-up and is willing to accept slightly higher risk of local recurrence when they convert from mastectomy to breast conserving therapy after neoadjuvant chemotherapy. But if they have unifocal disease and they had good response documented on post-treatment MRI, I think they have a very fair chance in terms of local control compared to mastectomy candidates. Now, what do I do with the axilla? It's slightly complicated in real practice, and there are lots of controversies about managing the axilla after neoadjuvant chemotherapy. However, for the exam, I always tell the resident it should be pretty straightforward and easy. If you have clinically node-negative patient, so no palpable disease and nothing on imaging, she got neoadjuvant chemotherapy. She remains clinically node-negative after neoadjuvant chemotherapy. We're gonna do a sentinel. If it's negative, no further surgery. If it's positive, they will get axillary dissection. The other scenario, you have a patient who is clinically node positive, got neoadjuvant chemotherapy, and then either they remained node positive after chemo or they got converted to node negative The answer for the exam is axillary lymph node dissection. It's a fair and safe answer, but we're going to talk a little bit about the controversies in this. So, locally advanced breast cancer, first step is neoadjuvant treatment, followed by surgery. If the patient is a good candidate for breast conserving surgery after neoadjuvant, we do a lumpectomy. Otherwise, we do a mastectomy. Axilla. Patient started off with negative axilla, got the chemo, she's still negative, she gets the sentinel, it's negative, no further surgery, it's positive dissection. If the patient started off with positive disease in the axilla, for the exam, even after neoadjuvant chemotherapy, regardless of the response, we proceed with axillary lymph node dissection. Adjuvant treatment, after we completed neoadjuvant surgery, all patients should be considered for radiotherapy. Most of them will be candidates. HER2 positive patients will continue with anti-HER2 treatment for 1 year. And there are some candidates that will continue for 2, but the classic is 1 year. And if they are hormone positive, they will go on anti-estrogen treatment, just as early breast cancer. All right, the fun part, the trends in axillary management. It would make studying for breast a little bit complicated. So again, more is not always better. Yes, in the past, everybody used to get axillary dissection, and then, I don't know, 25 or 30 years ago, when Armando Gugliano first recommended doing the sentinel lymph node biopsy for breast cancer, he was called a dangerous surgeon and that he was putting patients' risk at life. And then a few years later, sentinel lymph node biopsy for the breast became pretty standard, and not everyone got axillary dissection, only the one that got positive sentinel nodes. And then new trends came up and said, even if the patient has positive lymph node, we could omit dissection if they fall under certain criteria. Why? Why bother all of this? Why not just do dissection? Because of the morbidity. So axillary lymph node dissection is associated with chronic pain, chronic numbness, and sensation alteration in the upper inner arm, risk of nerve injury causing shoulder, difficult mobilization or wringing of the scapula. And even if we do a perfect surgery and we preserve all of the nerve bundles and we do not touch any of the nerves, there is still the monster lymphedema. There is always a chance of lymphedema. And no matter what is the technique, as long as you're below the axillary vein, you're minimizing the risk of lymphedema, but it's not zero. You will still see patients in the clinic from time to time coming with swollen arm and lymphedema. Lymphedema is very, very, very difficult to treat, and it causes disfiguration for the patients. It causes limited mobility of the arm, recurrent infection secondary to the lymphangitis. So that's why we're going down and down and less and less and less on axillary lymph node dissection and trying to replace it with other treatments. And this is why we're going to talk about the trials that talk about downstaging surgery in the axilla. So Z11 and AMAROS, I'm sure most of you, the R5s, are familiar with those trials. I'm summarizing it here so you can go back to it quickly whenever you want to remember the indication. The Z11 included, it's a randomized controlled trial that included patients with T1 or 2. So tumors up to 5 centimeters, whom are undergoing lumpectomy followed by radiotherapy. They're clinically node negative and they have 1 to 2 positive sentinel lymph nodes. And then they get randomized either to dissection versus nothing. So T1, 2, and 1 to 2 sentinel nodes positive. So 1, 2, 1, 2. All right. So small tumors that are going to undergo lumpectomy and will have radiotherapy, and they will get sentinel. Even if they have 1 or 2 positive sentinels, they will be randomized to dissection or nothing at all. So no difference in 10-year local regional recurrence between dissection and no dissection group. And no difference in the overall survival in the 10-year follow-up. So the Z11 was published, and they had their results after a 5-year follow-up, and then 3 years ago they published their 10-year follow-up. And there is no difference between the dissection versus sentinel lymph node alone group. AMAROS, again, was a randomized controlled trial, T1 or 2, clinically negative axillary exam, and they had positive sentinel lymph node. They did not require that it's a lumpectomy patient, lumpectomy or mastectomy, and they did not put a limit on the number of positive lymph node, any number, 1, 2, 3, 4. And then they got randomized to axillary lymph node dissection versus axillary radiotherapy. 5-year axillary recurrence was no difference between the two groups, 0.43 in the dissection versus 1.19 in the radiotherapy. What was significantly different is the lymphedema and arm morbidity, which was much less with the radiotherapy group. The 10-year follow-up came out a couple of years ago, and there was also no difference in the survival whether a sentinel node positive patient was dissected or only received radiotherapy. What was different is the chances of getting lymphedema. Remember, axillary lymph dissection by itself increases the chances of having lymphedema. And if the patient has lymph node positive and you do a dissection and she will get radiotherapy, the chances of lymphedema after radiotherapy also goes up. So the combination of dissection and radiotherapy increases the incidence of lymphedema. So if the patient is anyways getting radiotherapy to treat microscopic disease in the axilla, then axillary lymph node dissection can be omitted. Remember, Z11 and AMAROS for early breast cancer who were clinically node negative and were only found to have deposits in the lymph nodes after sentinel lymph node exam. They did not come with palpable disease or abnormal axillary lymph node, and they did not include any patient who had neoadjuvant. Those were early breast cancer going for upfront surgery. Okay, so this is like your map to navigate axillary management. Clinical and imaging assessment, clinical by palpation and imaging by ultrasound. If my patient is clinically node negative and I'm going for upfront surgery, she has early breast cancer, I'm gonna do a sentinel lymph node biopsy. If the sentinel lymph node biopsy is negative, no further intervention. If the sentinel lymph node biopsy is positive, my next question to myself, does the patient fall into the Z11 or the AMAROS trial? The Italian breast cancer was another similar study, and it showed no difference with dissection. So if my patient falls into this, even if they have a positive sentinel lymph node biopsy, no need for axillary dissection. The patient will get radiotherapy if she had a lumpectomy in the Z11, or if she was a mastectomy, she falls under the AMAROS and she will get axillary radiotherapy. So clinically node negative, sentinel lymph node turned out to be positive. If the patient is under Z11 or AMAROS, no need for further dissection and just radiotherapy. If my patient was clinically node negative and for whatever reason she got neoadjuvant chemo, she was triple negative or she had a T4 or HER2 positive tumor. After the neoadjuvant chemotherapy, there is absolutely no contraindication for sentinel lymph node biopsy because they used to say neoadjuvant is a contraindication for sentinel. It's not. And if the sentinel lymph node is negative, no further treatment. If it's positive, then I must do a dissection. Why? Patient does not fall into this because she received neoadjuvant treatment. And the patient, despite getting chemotherapy, she still has disease that was resistant to treatment. It survived the chemo. So if I have a sentinel lymph node positive post-neoadjuvant chemotherapy, I'm doing axillary lymph node dissection. All right, this is for clinically node negative. What if I'm dealing with a clinically node positive patient? If for whatever reason I'm going for upfront surgery, then it's very obvious. I'll do axillary lymph node dissection because she's clinically node positive. She has big nodes. She has fine needle aspiration confirming the presence of mets. If she's going for neoadjuvant chemotherapy and they remained after chemotherapy node positive, we're doing a dissection. If after chemotherapy they got converted to node negative, and this is where I told you earlier that in exam, it should be easy. It is safe to say that you will proceed with axillary lymph node dissection. But if at your center and in your program and your board, it's very well known that there are certain patients that can be spared dissection, then you could tell them that in the past, old training was everybody should get a dissection. But nowadays, once she's converted from positive to negative after chemotherapy, I can offer the patient sentinel lymph node biopsy. If the sentinel lymph node biopsy is negative, no further dissection, but if it's positive, I'll proceed to dissection. So what are these criteria? You have to use dual tracer, the blue dye and the technetium, to increase your nodal identification rate. You have to at least find 2 sentinel lymph nodes, and you have to have an expert pathologist who will do for you immunohistochemistry to identify micrometastases. So if I have somebody who had positive nodes and I gave them chemotherapy, and then after chemotherapy, there is no more palpable disease, the ultrasound, all of the nodes look normal, I will discuss with my patient that I could do sentinel lymph node biopsy, but I have to have dual tracer, and at least I find 2 lymph nodes, and I ask my pathologist to do immunohistochemistry. If I can fulfill this criteria, then it is safe to do sentinel lymph node biopsy, and if it's negative, no further surgery. If it's positive, we proceed to dissection. Why? Because we are talking about disease that survived chemotherapy. Recurrent breast cancer. So it sucks. You do everything by the book, you follow the guidelines, and then the disease comes back. So what do? You have to start all over again. Pretend that this is new presentation. You restage the patient. You biopsy things. You don't assume that this is a local recurrence. And keep in mind, an ER/PR positive, HER2 negative breast cancer in this patient 10 years ago might be ER/PR negative this time, HER2 positive. So that's why we rebiopsy recurrences, first of all, to confirm that this is a recurrence, and then to reorder the markers. And remember, basically in breast cancer treatment, you can repeat everything except radiotherapy. Very select studies nowadays say that we could re-irradiate irradiated breast, but generally speaking, you cannot re-radiate. 3 types of recurrences: local, regional, and distant. For local, if you did a lumpectomy and radiotherapy, you do a mastectomy, plus minus sentinel or axillary, depending on what was their previous operation in the axilla. If she had previous dissection, then you will not do anything. If she had previous sentinel, you could redo sentinel, and if you don't find the sentinel, you do a dissection. If she had prior mastectomy and she has local recurrence in the mastectomy bed, you do surgical excision of the chest wall, plus minus radiotherapy. Regional recurrence, so there is no recurrence in the breast or the chest wall. The recurrence is in the lymph nodes. If they have an axillary recurrence, we do axillary dissection, plus minus radiotherapy. If they have regional recurrence in the supraclav, We do not treat supraclav lymph nodes in breast surgically, never. You have a supraclav lymph node secondary to breast cancer, they get chemotherapy and radiotherapy. Same thing goes for the internal mammary. You give them systemic treatment plus minus radiotherapy. So only axillary recurrence is what we deal with surgically. Supraclav and internal mammary, we don't touch surgically. We offer systemic treatment and radiotherapy. Distant recurrences, if it's bone negative, I mean visceral metastasis, like lung, lymph nodes, liver, you do your receptor status and start systemic treatment. Bone positive disease usually is easier to deal with, especially with the new treatments to control the bone disease, such as denosumab. It's a monoclonal antibody that reduces the fractures, pathological fractures, and improves survival. This is again the NCCN for recurrent breast cancer. Special consideration, inflammatory breast cancer. I always tell the resident, I call it the AAA. It's aggressive, it is like the worst. We always start with neoadjuvant chemotherapy. We don't need to think about it. And we always do a modified radical mastectomy, regardless of the response to chemotherapy, because all of the trials in breast cancer, they usually do not involve inflammatory breast cancer. And because there is invasion of the dermal lymphatics, the risk of recurrence is high. So we don't offer lumpectomy and sentinel in inflammatory breast cancer. It's the AAA. If there is no good response to neoadjuvant chemotherapy, because if you will see someone progressing on chemotherapy, it's going to be an inflammatory breast cancer. You switch to second line, and in sometimes desperate times where no chemotherapy is working, you could offer radiotherapy first. Do not operate on a progressing inflammatory breast cancer. It's a sign telling you to back off. You're giving chemo, it's progressing, second line, progressing, third line, progressing. You ran out of options, give them radiotherapy, but do not operate on it. Pregnancy, remember, there are 3 forbidden things in pregnancy: radiation, tamoxifen, blue dye. Once you know what's contraindicated, then you can navigate your way into their management. First trimester, you could discuss termination of pregnancy, but due to culture and religion, it's usually not favorable. Most of the patients here continue with the pregnancy, and given that their first trimester, you cannot do radiotherapy after the surgery because they're gonna be through their second and third trimester. So you're gonna do mastectomy. And if you do not have the technetium, you only have the blue dye, then you're gonna have to do a dissection. So basically, first trimester, most of the time they get modified radical, okay? Second trimester, if they're early in the second trimester, again, you will be stuck that you cannot do a lumpectomy because it's gonna be a long way before they deliver and get radiotherapy. So you will offer them a mastectomy unless they have an indication for chemotherapy. So let's say she's node positive or a big tumor and she's gonna get chemo. Chemo is safe in the second and third trimester, not in the first. So you could start with chemo. She finishes the chemo. It takes usually 5 to 6 months. She delivers, you do the surgery, and then radiotherapy. Third trimester, if they're towards the end, wait for them to deliver and then deal with the cancer. If not, you could offer lumpectomy because they're close to delivery, and then after delivery, you give them adjuvant treatment. This is another way of looking at it in the Toronto manual, before 20-week or after tweak. I prefer the 3 trimesters. Phylloid tumors, 3 types: benign, borderline, malignant. Benign is basically just as a fibroadenoma that's big but has a chance of coming back after surgery, and that's why we need wider margins. The borderline ones, usually it's very hard to tell with certainty the subtype of the phylloid until you completely excise it. For borderline, if you found on core biopsy that it's borderline, make sure you take a 1 cm margin to prevent local recurrence. Malignant phylloids, again, you have to excise with 1 centimeter minimum of tissue around it. When the tumor is large with respect to breast size, this may require mastectomy. But don't start with a mastectomy in a benign or borderline phylloid. Offer them first wide local excision. But if it's malignant and it's large, then you might end up with a mastectomy. Okay, there is a very nice note from the NCCN. I cut it and pasted here because it's a common question that comes. For malignant or borderline phylloid, wide excision means excision with the intention of obtaining surgical margin of more than 1 cm. I go in and I take tissue all around and I aim to take 1 cm. Final pathology tells me that I have negative margin, but not all of the areas are more than 1 centimeter. This should not push me to go back and do a mastectomy. So I aim for 1 cm, but if the final pathology comes and there are some areas that are less than 1 cm, but they're negative margin, then just observe the patient. If they got a recurrence, then at that time you will discuss with them that you already had a big tumor and you removed as much margin as you can and now they have a recurrence, then you offer mastectomy. But don't go for a mastectomy on a negative margin. If it was negative, but not 1 cm, it's fine, just follow it. Usually it doesn't go to the lymph node, so nodal assessment is not necessary. All right, so I think we're done here. We're gonna go back to the questions that were chosen from the beginning.
All right, so we start the MCQ questions now?
Yeah.
All right, perfect. So we're gonna start with this question. Okay.
A lady has a lumpectomy that shows a 5 millimeter focus of DCIS, negative margins, as well as some LCIS that is positive at the margin. What's the best management? Whole breast irradiation, mastectomy, re-excision, tamoxifen. The majority answered mastectomy.
Yes.
Okay. So I see the point why people would choose mastectomy, but it's not the right answer, unfortunately. Doing a unilateral mastectomy because there is LCIS does not change a patient's survival because the risk is there in the other breast. If I'm treating LCIS, it has to be both breasts. It's a marker that this patient is at high risk of getting cancer. So even if on my specimen, I have this specimen, and inside the specimen, there is DCIS. The margin for the specimen for the DCIS is negative. Even if I find LCIS here or here, it does not warrant that I go back at all. Taking more breast tissue for LCIS is not therapeutic. The only surgery for LCIS that's curative is bilateral mastectomy. So we do not need to go back for a negative margin for LCIS. The best management in this patient is whole breast radiation. Why? Because she had DCIS and she had a lumpectomy. So she absolutely has to have whole breast irradiation. Nothing in the question showed me that there is an indication for tamoxifen because we said anti-estrogen treatment for DCIS is considered in select patients, large DCIS, young patient, high-grade comedo necrosis, and positive family history. So the right answer is to go for whole breast radiation.
All right, we'll go for the second question then.
Young lady with 5 centimeter DCIS, multifocal with multiple positive margins post-lumpectomy. Best treatment, re-excise to negative margins, radiation, simple mastectomy and sentinel lymph node biopsy, observation.
Meanwhile, Doctor, if you'd like to check of the Q&A panel to choose any you'd like to answer after, feel free.
Okay, somebody is asking what is a negative and what's a positive margin. So when we say margin, it means after the pathological examination of the specimen. So I did lumpectomy, I took the lump out, and then the pathologist will examine the surface of the lump to make sure that wherever I cut, there is no residual or disease reaching the margin. Because if they tell me that this is my lump and cancer is reaching the margin of the lump, it means I removed the lump with a positive margin, so there is cancer left in the patient. A negative margin for breast cancer is negative margin, even if it's less than 1 millimeter. It doesn't matter. Negative is negative. No cancer cell on the inked surface of the tumor. If you go to the pathology with a breast lump, the first thing that they're gonna do, they're gonna paint it. The anterior green, the posterior black, the lateral, the medial yellow, whatever it is. So when they slice it and process it and they look under the microscope, they're gonna see the ink, the black, the blue, the yellow. And then they could tell you if the cancer cells are reaching the inked margin. So for breast cancer, all what you need is a negative margin, meaning no tumor reaching the inked margin. For DCIS, however, because biologically it's different and the spread within the duct is different, you need a 2 millimeter margin to call it a negative margin. Okay.
We can share, we're going to share the pre-session post. That was the pre-session post answers.
Right. Most of the answered the right answer, which is simple mastectomy and sentinel.
Now we're going to share this, the post-session answers.
Okay.
Right.
So yes, it is simple mastectomy and sentinel. She had a large area of DCIS, and she's young, and she has multiple positive margin, not just like one margin. It means like many areas she had positive margin. So, okay, good.
Right. We can go to the next question.
50-year-old female has branching microcalcification on screening mammography. Biopsy comes back as sclerosing adenosis with a focus of pleomorphic LCIS. What should I do?
Give them a few seconds to answer.
Yeah. And meanwhile, we'll look at the next question. All right. So regarding patient that meet criteria for ECOSOG Z11, that in the, I think there is a typo, I'm not sure what's this word, biopsy of the sentinel node informed 1 out of 2 clinic node with ECE of 2 millimeter. Okay, I think it's a bit full of typos, but I think I get the question. Yes, so if you're talking about extranodal extension, so extranodal extension means that the lymph node got so full of metastatic cells from the breast cancer to the point that the metastatic cells started to come out of the node. This is a pathological term. It's called extranodal extension. Extranodal extension was a contraindication to enroll in the Z11, and those patients went on to have a dissection because it's an aggressive, it's a marker of aggressive disease. It means that the tumor cells are replicating so fast in the lymph nodes, and they were excluded from the Z11. However, the AMAROS 11 did not exclude extranodal extension. So if the patient is still T1, T2, she has positive sentinel, even if they have extranodal extension, you could apply the AMAROS trial on them. But yes, you're right, they don't fall under the Z11. All right, so yes, wire localized excision, and the key is the word pleomorphic, because once we see pleomorphic, we have to rule out adjacent DCIS or malignancy.
Right, that was the pre-session answers, and the post-session answers, they're the same.
Okay.
All right.
No, actually, they're going to mastectomy. They answered more mastectomy.
Yeah.
So,
yeah,
again, I want to stress again and again and again on this. If I'm offering mastectomy to an LCIS patient, it has to be bilateral mastectomy, and it's not the first choice of treatment. So unilateral mastectomy is not treatment for LCIS. I'm doing a wire localized excision of that area because we discovered pleomorphic LCIS. I have to make sure that in that area we are not missing DCIS or cancer. If there was an option of bilateral mastectomy, then yes, it would be okay to think about mastectomy, but unilateral, no.
We can go to the next question.
Mm-hmm. 50-year-old lady with T3N2 disease. She is ERPR negative, HER2 positive. What's the best approach? Neoadjuvant chemo followed with Herceptin, followed by surgery, followed by Herceptin for 1 year. Neoadjuvant chemo, Herceptin, surgery, chemo for 1 year. Modified radical mastectomy, neoadjuvant Herceptin followed by surgery.
End the poll in 30 seconds.
Okay, and we'll take a look at the questions. How can we'll take this record? I think they're talking about the slides. You can share the slides with everybody.
Yes, all the slides and the sessions are going to be uploaded on our website.
All right, okay. Can you explain in brief what is neoadjuvant? NAC is neoadjuvant chemotherapy. And when we say neoadjuvant, it means treatment before surgery. Adjuvant is treatment after surgery. Okay, the next question, what is your standard management of positive axilla pre-neoadjuvant chemo that it disappeared? There you go. What is your standard management of positive axilla pre-neoadjuvant therapy that's converted into negative axilla post-neoadjuvant? So yes, this surgeon is also talking about one of the things that we discussed. If we have a node positive and they got converted to node negative, clip carbon and radioactive seed. So unfortunately, we do not have the radioactive seed here. We do have the regular clip, and we use it sometimes when a patient has a single enlarged lymph node, and we take a biopsy and we confirm that it's malignant, and we place a clip in it. And then when we do our sentinel, we see if our sentinel is the clip node, but unfortunately we don't have the radioactive seed. The radioactive seed was shown in the trials in MD Anderson that it really decreases the false negative rate. And it's called targeted axillary dissection. I'm assuming the person asking this question is already a surgeon, not a chief resident. But yes, radioactive seed is actually the best thing to decrease the false negative rate and increase the identification rate, but it's not available here. Okay.
Right. So these are the pre-session answers. 44% answered answer B.
I don't see them.
All right, we'll reshare them again.
Okay. Okay.
These are the pre-session, and now we're going to share the post-session.
Okay, so more towards the right answer and less for the B. The right answer is A. The Herceptin is what we continue for 1 year. It's not the chemotherapy. All right.
Now for the last question. Show up now, yes.
32-year-old female with enlarged axillary lymph node. Fine needle aspiration was positive for metastasis from mammary carcinoma. Workup negative for primary breast mass, including clinical and radiological assessment. So what's the management? We did not discuss this, but I love this question. It's a classic exam question. Modified radical mastectomy and radiotherapy, axillary dissection and radiotherapy, axillary dissection alone, modified radical mastectomy alone.
Right, we'll give them
Meanwhile, somebody is asking about immediate versus delayed breast reconstruction. What's your opinion? So I'm an immediate breast reconstruction type of surgeon. I prefer the immediate reconstruction, first of all, 1 surgery. Second, psychologically, patient is going in for a mastectomy, but they still come out with a breast. There is no absolute contraindication to place an implant or a tissue expander, even if we know that the patient will get radiotherapy. If after radiotherapy there was some change in the contour over the implant, this could be fixed in outpatient procedures such as fat injections. Most of our patients come with advanced disease, and most of them, they need radiotherapy. If we do mastectomy with no recon and we give them radiotherapy, the skin over the chest wall becomes very tight, and then expanding this becomes difficult. And then the only option we're left with is autologous reconstruction, which is more complex. It's obviously a valid option, but it's more complex. So I prefer immediate reconstruction whenever feasible.
Right. And now for the post-session answers.
All right, okay. So in real life, A and B are both right answers, and there are no randomized trials about this topic, which is axillary metastasis from unknown mammary primary. So you have axillary lymph node, but nothing in the breast. The most important thing in the exam that you're gonna say, I'm gonna review the imaging, I'm gonna make sure that the patient gets an MRI. This is actually one of the indications to do MRI of the breast to make sure that I'm not missing a small occult primary. And if all of the imaging is negative, classic exam answer would be modified radical followed by radiotherapy, because you don't know where is the primary, or maybe there is no more primary in the breast. Sometimes tumor regress and the primary disappears and the mets grow. And this would happen sometimes. But to be safe in an exam setting, you would choose modified radical and radiotherapy. For me personally, in real practice, I go for dissection with radiotherapy of the breast and the axilla. So even if there is a tiny occult or regressed primary in the breast, it will get exposed to radiotherapy, provided that the patient has a negative MRI, and they will be committed to close follow-up.
Right. If you'd like to take last few questions, Doctor, from the Q&A panel before we...
Few question, but I don't understand it. Whether breast is conserved in MRM? No, it's not. Modified radical mastectomy means removing all of the breast tissue, skin, nipple, areola complex, and axillary lymph node. So modified radical mastectomy is not preserving the breast or the axilla. There was also a question about what are the contraindication for neoadjuvant chemo. So basically, there are no contraindications in terms of like neoadjuvant chemotherapy. It's whether the patient is a good candidate or not. So if there is an indication, which is locally advanced disease, but if the patient has early breast cancer and she doesn't have node positive and you can do lumpectomy, then there is no need to give neoadjuvant chemotherapy, but we wouldn't call it contraindication. We would just say that there is no indication for neoadjuvant chemotherapy. Okay, I think, those are the questions showing here. Few more questions.
Okay, thank you so much, Doctor, for this amazing and informative session. And thank you everyone for attending the session. We know these are difficult times. We personally lost our dearest surgeon yesterday. The surgical community in Kuwait are mourning one of the most active surgeons, a professional colleague, a brother who never hesitated to help his fellow doctor who we lost him yesterday after being infected with COVID-19 virus. Dr. Abdullah Shaib was a general surgeon who volunteered in the field hospital built to help in the war against this pandemic. Our condolences goes to his family and his wife and all the medical community. We would like also to thank you once again, Doctor, for joining us today on our platform. And would like to have two announcements for the audience. First, our next session is going to be next week. It's going to be about endocrine diseases with Dr. Salman Al-Safran. And stay tuned for the R5 resident. We have a special series that's going to start on the 1st of August. We're going to announce it tomorrow, and it's going to be a limited seating only for the R5 surgical resident. Also, don't forget to take your phone out and scan the QR codes that will help you register to the next session, and you can check out our Instagram, Twitter, and website, and check out our podcast. And yeah, so thank you everyone for coming, and thank you again, Dr. Nora.
Thank you
for
so
being
much
on.
for the invitation, and please accept my condolences. Take care and see you. Good luck on your exam.
Thank you. Thank you very much, Doctor.
Thank you. Bye.